Welcome back to my channel. Here is Dr. Akbar, or my full name is Dr. Usman Akbar. I'm going to talk about a very important ocular condition that relates to your whole body as well. And in this presentation, I'm bringing forward idiopathic intracranial hypertension. The biggest thing about this condition that I'm going to discuss is, number one, I will present a case here without revealing the identity of my patient. And secondly, I will talk about how this condition happens and what can be done about it, its correlation and differential diagnosis, and things like that. We'll go over it in a lot of detail. If you have any questions, ask me in the comment section. Otherwise, stay tuned till the end of the video because there will be a lot of things step by step, and in the end I will conclude the things. Okay, so let's go over the case first. So I got a female. She was only 14-year-old and she presents with distance blur, fluctuating visions, and she was diagnosed with pre-diabetes as well as weight gain, and she got iron and metformin on her medication list, and she was diagnosed with amblyopia for about 3 years, and she's wearing glasses now. Okay, and has a family history, diabetes, hypertension, heart disease, and high cholesterol in her family history. And she was born with a cardiac condition called coarctation of aorta, which was surgically fixed after the birth. And she had some other things going on in the past medical history, which are, for example, tonsillectomy, polycystic ovarian syndrome, restless leg syndrome. Okay, and on the review of system, I found that she has some PCOS and increased blood sugar. Okay, and her BMI is high. Okay, BMI is high, blood pressure is 135/87, visual field on the confrontations is good in both eyes, is full. And when we check her vision, the uncorrected vision is 2100 right eye, 2080 left eye, and near vision is really good. The distance vision is reduced, as you can see, and besides that, other ocular testing are pretty decent. And if we give her the glasses, the vision is 20/20 in both eyes with this kind of prescription. Okay, remember, she's a female with polycystic ovarian syndrome, gaining weight, got pre-diabetes. Okay, keeping you guys with me. Okay, so when we look in the NSAC, in the front part of the eyes, things are pretty consistent. She got a little bit of papilloma in left lid, some scurf in the lids, mild injection in the eyes, and overall the pressure is perfect. 10 right eye, 14 left eye. Angles are really good, wide and open angles on the Von Herrick estimates. But things start hitting in when we look in the back of the eyes. What do we see? When we look at the optic nerve head of this patient, we see that there is indistinct margins with mild elevation, and CDs are about 0.2 both eyes, and the indistinct margins are basically in the right eye. Okay, and besides that, the AV ratio and all those things are good. There is no diabetic retinopathy going on in the back. We are happy, the patient is happy, besides having those visual fluctuations and all those things that I just described. FDT was done. It's a screener visual field that came back normal. Okay, even though there were several fixation errors when the patient was performing it, but still there were, overall the FDT is normal. Okay, that's why I don't rely too much on the FDT, even though I still do it, but still it's not a very reliable test because there is a better field. That's why we ordered that field in this patient. Let's go over that. So first of all, I would love to see OCT of this kind of patient, and that's what it shows. I can see that in both eyes, I don't see the cup, optic nerve cup, I barely see there. So I am seeing a thing called filling of cup, which is an initial sign that relates to what I'm seeing inside the eye, which means there is mild elevation. A mild elevation presents like filling of the cup inside the nerve that we can verify with the scan called OCT. Okay, and this is that scan right now. And when I'm looking at it, you can see the cup volume is 0. okay, which means there is no cup, okay. CDs, barely any CDs, look at that, very small CDs, okay. RNFL, we got some RNFL, symmetry is 89%, that's cool, but I see some swellings going on there, okay. So besides that, when we are looking into it, second thing, as I mentioned, a very important thing is visual field of the patient. The FDT is a screener, but I need a better and advanced visual field. So I went forward with a 24-2 central threshold visual field HVF. Humphrey visual field is my favorite in this regard, and that's how the field looks like. Okay, the visual field looks like, and this is how the back of the eye, we took the pictures, this is how the back of the eye looks like. I see indistinct margins here, indistinct margins here. I see some signs of elevation going on in the back of the eye, in the optic nerve. That's serious. You cannot ignore it, you cannot let it go, you have to investigate it further. So when I am reporting my visual field, this is what I said: reliable field and isolated area of inferior nasal loss in the right eye. So there is some loss going on in the visual field of the right eye, and several indistinct areas of loss and scattered defects in the left eye. So both eyes are having some problems. Look at this. This is the one eye, this is the other eye, right eye, left eye, okay? Both eyes are showing some problem, and that is verified with my favorite test, Humphrey visual field, which is showing problem in both eyes. Especially look at the left eye, several indistinct areas of the loss and the scattered defects in the left eye. B scan was done to rule out if there is anything called optic nerve head drusen, which could present in a similar way but not exact way, okay? Then comes a game changer, a very important test that has to be done to rule out if there is anything else causing this thing, okay? That's called MRI. MRI with and without contrast was ordered for the patient, and patient was also told, and the patient's mom was also told, that depending on the results of the test, we might need a lumbar puncture depending on the results of MRI. Lumbar puncture is a tap in the back to see the pressure, to see the CSF pressure. CSF is cerebrospinal fluid. We love to see that pressure because it has a lot to do with this kind of swelling and with many other related conditions that can cause similar presentation, okay? And we also communicated with the primary doctor, PCP, and here we go. The patient comes back, and now the patient wants contact lenses. Good thing is she's still 20/20 with the glasses / contacts. Intraocular pressures are good. 15 right eye, 14 left eye. I love that. But when we look at the nerve, still we are seeing problems. We are seeing elevation of the disc. We are seeing swelling. And another thing this time we see is there is some hemorrhaging going on. When there is a hemorrhage going on next to the nerve, at the nerve, near the nerve, it's critical, it's important, it's getting to a higher stage now, okay? And we did the Humphrey visual field immediately. You see that? You see the defects? It's getting bad. It's getting bad. We don't want that. We don't want that. If you look at the previous visual field, that's way better than this one. So it's getting worse, which is not a good sign. So patient is losing something. So based on her consistently higher BMI, she is getting fat and fat. She's not losing weight, she's gaining weight more and more. Consistently high BMI and changes in the optic nerve head status in the OCT and negative MRI. So now we got a report that the MRI is negative. There is nothing in the brain, there is nothing in the tract that is causing that swelling as such, okay? So MRI came back normal, and based on all those, as well as the direct assessment of the patient's optic nerve and the whole eye, we diagnosed that patient as idiopathic intracranial hypertension. That's important, okay? And that's why we refer the patient to a neuro-ophthalmologist. It's very important to consult with a neuro-ophthalmologist in that kind of scenario. And here is the billing. I don't think you guys want to know about the billing, that how much was the patient charged about it. Let's now go over the condition in itself. Okay, so annual incidence, we see 1 to 2 per 100,000 patient population in America, and the higher incidence is in obese women in the age range of 15 to 44. It can be seen earlier as well. For example, some cases you can see even in the infancy, but this is the most common age range, 15 to 44, obese female. Okay, and the incidence and prevalence is getting higher and higher. Why? Because the obesity is getting higher and higher. Every day people want to eat. People want to eat more and more and more and more. And they keep gaining weight and they keep getting into the troubles related with the obesity. And that's why this condition is also getting common in the world, especially in USA and other parts of the world where the obesity is going higher. Okay, how does it happen? What's the pathophysiology behind it? The pathophysiology is that it can result from increased CSF or cerebrospinal fluid production that exerts the pressure on the brain as well as the optic nerve. Okay, and that's what causes that swelling that I was showing you in that picture. Okay, so variable level of severities and structural and functional changes are happening because of that or observed because of that, and there are several causes or correlations or associations with this condition. Number one, as I mentioned earlier, is obesity. There are many medications that can lead to this kind of condition. For example, tetracycline antibiotics, growth hormones, high dose of vitamin A. Sometimes patients have acne and they are taking high dose of vitamin A, and for many other conditions patients are on high dose of vitamin A, but that can also lead to this. Okay, cyclosporin, oral contraceptive pills. Can you imagine? There are so many females who have these pills. Okay, lithium, many psychiatric condition related patients, they are on lithium, amiodarone, and sulfa antibiotics. Can you imagine? There are so many patients who are on sulfa antibiotics. They can also cause that. So you need to know this list. Polycystic ovarian syndrome, that's another thing. So the things that I've underlined are also present in my patient. Polycystic ovarian syndrome, sleep apnea, hypoparathyroidism, lupus, kidney disease, blood clotting disorders, anemia. That's why my patient was on iron tablets. So she has anemia. Addison disease can also be connected with it. So there are many correlations and causations in this perspective that we need to know, and there are so many things that you can just manage this condition just by switching off that antibiotic, by finding some alternative, talking to the primary doctor that, doc, we need to switch this to something else, and so on and so forth. Okay, clinical picture. These patients, they come with headache, and there are some associated factors. Usually there is an associated factor. Like in this patient, as I mentioned, there is an association of obesity, anemia, polycystic ovarian syndrome. 3 very strong associations I am finding in this patient. Okay, so associative factor, you have to know about your patient. Then comes papilledema. You will see the nerve swelling, normal MRI, and fluctuating vision. This is what this patient was coming with, that, doc, my vision is fluctuating. Sometimes it's good, sometimes it's bad. Today is 20/20. Visual field loss. This patient had that. Enlargement of blind spots. So when you are checking for the visual field, look at the blind spot and see if it has enlarged or not based on the field deficit that you can see from there. Flame-shaped peripapillary hemorrhages. When this patient came second time, I told you that this patient is having that bleeding going on near the nerve. Peripapillary hemorrhage means that, yes, there is some bleeding going on near the nerve margins or in the nerve periphery, in the nerve perimetry, somewhere in that nerve area you see that. Optociliary shunt vein could be seen sometimes. The nerve could sometimes be just pallor. It could be a pale nerve. So you need to look at it very carefully. Venous engorgement, hard exudates could be seen. Telangiectatic vessels on the disc surface, sometimes you see those. So that's why taking pictures, documenting it, and coming back to it is important. And when you look at the OCT, you will see the filling of the cup. That's what I was showing you in the OCT that I showed earlier. And you see some elevation also. You can literally calibrate that elevation on the OCT when you are sitting there, and then you can monitor it over time. But remember, there would be other conditions which will present similar to this condition. So you need to rule out those as well. Very important to rule out. That's why we did so many testing for our patient, including MRI. So bilateral papillitis, the nerve infection in both eyes could be like that. Pseudopapilledema could be like that. Hypertensive optic neuropathy, that could also present similar. And this patient had high blood pressure. The thing is, she has a history of coarctation of aorta that was treated surgically, and then who knows, it could be because of high blood pressure. She also has high blood pressure. Hypertensive optic neuropathy. So it's important to rule out. It's important to keep all those differentials right there. Leber hereditary optic neuropathy. So you might be just born like that with this condition that's causing all those things. Or diabetic patients can also have this kind of thing going on, this kind of scenario going on, this kind of nerve swelling going on, which is called diabetic papillopathy. So you need to know them. If you don't have in the back of your mind, you will forget it, you will miss it, you will cause problems to the patient. Okay, so things come back to you eventually. So you have to be very, very careful. Weight loss is one of the big treatments because of rising connection between obesity and this condition, idiopathic intracranial hypertension. Secondly, acetazolamide is also a very good drug that has shown promising results. And discontinuation of any causative factors. The factors that I was discussing, for example, some patients are on high-dose vitamin A or tetracyclines, the antibiotics, and many other things. So you need to know the causative factors and cut them off, okay? Surgical treatments come late, down the list, or depending on the patient scenario. So sometimes we have to consult with a neurosurgeon for the shunting procedures to lower down the pressure. So it depends. That's why we tell the patient that we might be doing lumbar puncture, the back, puncture, and check that opening pressure. We check that. We have to make sure it's not high, okay? And this is a very simple treatment. If you follow it, you get rid of it, okay? Depending on the patient scenario. But let's say the same scenario is coming with a patient who is pregnant. What will you do then? You cannot give them acetazolamide. You cannot tell them weight loss. There's so many things that you cannot do, okay, that you can do in another patient. So it's important to know what would you do if the patient is pregnant, because this condition is common in females. Do not recommend weight loss, okay? It's important that you don't tell a pregnant lady to lose the weight, because it's dangerous to her, it's dangerous to the baby. We don't want that. You can give acetazolamide up to the 20th week of pregnancy, not beyond that, okay? Remember, beyond 20th week of pregnancy or gestation, you cannot, after 20th week, cut it off, okay? Because there is a possible risk of metabolic acidosis, and of course, you need a lot of caution during breastfeeding also. So you need to be in touch with your doctor. Very, very, very critical, okay? Serial visual fields will be done in that kind of pregnant patient, and close observation if there is no threat to the vision. If there is a threat to the vision, you have to consult with a neurosurgeon who will do steroids, optic nerve sheath decompression, and shunting, or repeated spinal taps, okay? They have to do those things to make sure that the pressure remains normal. You have to do repeated spinal taps depending on the CSF pressure, depending on the patient scenario, depending on the visual field deficit. So it depends on all those testing that I was discussing and all the parameters. So patient to patient, it's a patient-based practice. It's not a book practice that, okay, you throw this book on every patient. No, it doesn't work like that. So let's say the patient doesn't need those things. I'm not going to refer her for optic nerve sheath decompression. So it depends on patient to patient. Some patient might need the decompression, okay, with the neurosurgeon. Some patient might need just a repeated spinal tap. So it depends, okay? I hope that helped all of you. If you have any questions, please ask me in the comment section, and you can go over it again because I think I was quite fast, but I wanted to make it as brief as possible. I hope that was helpful. If you have any questions, don't hesitate. Okay, thank you so much. Have a great day. Bye bye.